Hello, my name is Kathryn Farr, and I'm a student in the Doctor of Nursing Practice program at the University of South Alabama in the Adult Gerontology Primary Care track with a subspecialty in palliative care. The following video is a review of my DNP scholarly project. Since the beginning of my academic journey, I have focused my research and writings on oncology palliative care. The more I've learned and experienced during the required clinical hours, the more I've appreciated the need for expert palliative care within an oncology practice. Cancer is devastating, and many, if not all, of the oncology patients could benefit greatly from intentional palliative care. The quality improvement project I completed served as an example to the staff at the Cancer Center as to what a palliative care clinician could offer their patients. It allowed many opportunities for me to speak with the oncologists, the nurses, and the director of the Cancer Center, sharing a vision of developing a palliative care clinic within the practice. Thank you for your interest in my project, and I hope you enjoy the video. The title of my project is Improving the Perceived Self-Efficacy of Oncology Patients, Resulting in Optimized Symptom Self-Management. In other words, improving the self-confidence of oncology patients in their ability to cope with their disease and manage their symptoms leads to a decreased symptom burden and higher functional status. The theoretical underpinning of my project was the middle range theory of symptom self-management, which is the starting point for a discussion on symptom management. It combines the three components of the theory of unpleasant symptoms, which are the symptoms that the individual is experiencing, the factors that influence them, and the symptoms' consequences, with the self-efficacy theory of Bandura. The concept of enhancing PSE, perceived self-efficacy, through interventions leading to improved symptom self-management is a theme that emerges from both of these theories. A review of the literature found two approaches that are supported with high levels of confidence. First of all, patient-centered, highly individualized interventions have been found to be effective in improving symptom-related self-management. Secondly, an optimized PSE leads to improved self-management of symptoms and a reduction in symptom burden. The objectives of this scholarly project were threefold. First, it illustrated the integration of an oncology palliative care intervention in an outpatient oncology clinic setting. It also demonstrated the impact of an individualized psychoeducational intervention on the PSE of an oncology patient. Finally, it supported the Institute of Medicine's aims of providing patient-centered, efficient, and effective care. Now that you have some background information, I will talk about the project in more detail. The participants were adult oncology patients in active treatment. The potential participant pool included the patients from a single provider who was my DNP residency mentor, Dr. Tariq Adawi. The location was a community-based cancer center, which does not have an integrated palliative care team in place. After the patient's consultation with the oncologist, I met with the patient and introduced an informational sheet detailing the purpose, benefits, and drawbacks to participation. Patients that chose to participate were met with one-on-one in either the office, conference room, or a chemotherapy room. The Cancer Behavior Inventory, brief CBI-B, is a 14-item screening tool that I used. It involves a Likert scale from 1, not at all confident, to 10, totally confident, to measure the oncology patient's self-efficacy for coping with cancer. This was completed pre-intervention and then again immediately following the intervention. The CBI-B specifically measures the following 4 factors that are paramount to a patient's ability to cope with cancer: maintaining independence and positive attitude, participating in medical care, coping and stress management, and managing effect. PSE enhancing interventions were designed to address each of these 4 factors. The proven strategies included direct mastery, such as role-playing and visualization, vicarious experiences, such as hearing how a patient with a similar diagnosis and treatment successfully managed their symptoms, social and verbal persuasion, that included encouragement that one is competent to manage their symptoms, and accurately interpreting physiological and psychological cues in order to reach optimal symptom self-management. The actual intervention was a one-on-one, individualized psychoeducational interview with the oncology patient and family, if present with the patient. A script was developed that utilized the proven strategies outlined above. The strategies were woven into the script, focusing on the 4 factors: maintaining independence and positive attitude, participating in medical care, coping and stress management, and managing effect. The encounter lasted 30 to 60 minutes. The script was delivered in a conversational form with careful attention given to include the key components and strategies. The CBI-B scores generated the data for this project during the pre- and post-intervention screening. As you can see, the mean score of the pre-intervention CBI-B was 110.84, and the mean score of the post-intervention CBI-B was 115.48. This demonstrates a trend towards an improved PSE of the patients. However, the results were not statistically significant. A larger sample size or a greater difference between the 2 means would be necessary for statistically significant findings. It is my hope that this experience will serve as a gateway for the oncology practice to begin to embrace expert palliative care that goes beyond the usual assessment and care planning that is routine in outpatient oncology. It is an example of an innovative approach for improving patient outcomes and increasing the quality of life. And it is an example of a creative approach to identify these patients with low PSE who might be at higher risk of not completing their treatment due to symptom burden or ineffective coping. I want to say a special thank you for the support of Dr. Tariq Adawe, who has served as my DNP mentor throughout my residency, and Dr. Joyce Varner, my academic advisor, who has guided me with a steady and sure hand. Thank you.